The mechanics of the Wiley protocol. The delivery system of the Wiley protocol, transdermal applicator syringes. That means they're 3 ml syringes with a cap. So we actually have little tiny lines, 30 of them to measure, and a cap to take it off, and it's quite literally squirted on an arm and rubbed in the crook of the arm and up the back of the tricep. These syringes are color-coded green and purple to match dosing envelope instructions, and they're clearly labeled. Green is for estrogen and growth. Purple is for progesterone. There's a package insert with directions of contraindicated supplements and is included with the lunar and personal calendars. This included direction sheet for the Wiley protocol not only explains to the patient what it is, how to use it, where to put it, but what supplements and drugs might be contraindicated for usage with the Wiley protocol. The rational endocrinology of the Wiley protocol. Utilizing this rationale, you can examine the premise of my contention of a return to normalcy in terms of peer-reviewed scientific references. In other words, regarding cell proliferation and gene expression in both breast and uterus, you can look at the studies that follow and see that this is not an idea to sublimate symptoms. This is not an idea to compete with your peer group as a doctor. This is science. And we're going to do science and hope that logically it should work out. This is the plan. We establish endocrine thresholds in vitro and in vivo for G1 arrest on day 12. And we establish apoptosis on day 21, which can be extrapolated in serum levels, as well as being aware that changing the dose in the Wiley protocol every 3 days attends to 72-hour reset thresholds for steroid receptor rollover for both estrogen and progesterone. That's built into the dosing schedule. So you build it and they will come. Every 3 days the dose goes up and more receptors appear. And again, more references at the bottom, including my own. It's very important to me to be able to test my theory. So one of the papers that I've published over the last 8 years is in the International Journal of Pharmaceutical Compounding. It's peer-reviewed. The Standardization of Non-Sterile Compounding, a study in quality control and the assessment for hormone compounding. One of the biggest arguments you're going to get from your peers, or maybe even the federal government, is that compounding is hit or miss. That you as a physician can call in whatever you want, they can make whatever they want, they can charge whatever they want, and no one's watching. Well, for the past 8 years I've been watching. The Wiley protocol is standardized for methods, materials, pricing, and packaging. And what that means is all of the pharmacies that have a sign or listed on my website that provide the Wiley protocol have registered to do so using the same materials, the same machines, set on the same settings from the same suppliers. And they're put, of course, in the standardized packaging. Now, those pharmacies are tested every quarter by a third-party tester called Dynalabs in St. Louis, Missouri. Those results are fed back to me and my staff. If somebody quits testing, if they get low results, we step in and try to fix the problem. This paper that I published will show you that we get 98% consistent results from our pharmacies. So to try to call the Wiley protocol in to a pharmacy that's not registered with the program for study not only won't get you the same thing, you'll get a knockoff, but violates my patent. So please use a Wiley protocol registered pharmacy. You can find them on the website. We'll have a link at the end of this course for you to find one. If you'd like to try this on your patient, you know what you're getting. One of the problems with compounding is when you order Prozac, when you order clindamycin, when you order Celebrex, and your patient goes to a pharmacy, you know what they're getting. We decided for 100 pharmacies in the U.S., you should be able to order the Wiley protocol and know what you're getting. I should be able to run a study and know what the patient took, considering the outcomes. So please use a registered pharmacy. The packaging looks like this. As I said, it's color-coded in green and purple. The syringes must say the Wiley protocol and the ingredients printed right on the syringe. You can see the removable cap. We have no gasket between the green plunger and the hormones because they tend to leach rubber into the compound. We have the dosing schedule on the back. The basic Wiley protocol is W. If you would like to add a line to raise the dose or 2 lines to raise the dose, up to 4, we have that printed for the patient. The pharmacy will circle your prescription and the patient knows how to take it. Anything above +4 will turn off the receptor. So you must spread it out during the day, and we'll go through TID dosing. This is BID dosing. We have the dosing schedule on the back. The basic Wiley protocol is W. If you would like to add a line to raise the dose or 2 lines to raise the dose, up to 4, we have that printed for the patient. The pharmacy will circle your prescription and the patient knows how to take it. Anything above +4 will turn off the receptor. So you must spread it out during the day, and we'll go through TID dosing. This is BID dosing. This is progesterone. In a purple package, you see the same logic with a basic dose plus, and here we don't have plus. We have -1, -2, -3, -4, because the basic Wiley protocol, if it is absorbed correctly and dosed correctly, is almost pregnancy levels. It's very high on day 21, 22. So we would never put in more. We would, in fact, down-regulate it depending on the patient's needs and response and blood work. And here we have the basic dosing for the Wiley protocol again, just as we did for the estrogen. Now, with every package that you just saw comes a calendar. The calendar is very important because it's how they're going to report symptoms to you and not lose their place. We are working on an electronic version of this, which will be a Wiley protocol app. So the patient can use an app which is reported to you and their pharmacies for symptoms, for dosing, for changes in dosing. But for now, in paper, the woman receives a personal calendar, a lunar calendar, and do not use the Gregorian or Julian calendar. This would destroy the potential for normalization of ancient hormonal responses to photoperiod cues. What that means is human beings out in the world exposed to light and dark cycles had normal rhythms. Our modern calendar is an artificial measure of time that was instituted by the Romans to stamp out paganism and any other culture that acknowledged moon time. Our bodies did not evolve in Roman times. We lived in a cosmic time for 13.7 billion years, which means we evolved in moon time. Women have periods in cycles of the moon. Women who are not on lunar cycles are affected by artificial light. And that's why the personal calendar is useful. We can't go back and just make them go camping. We're going to have to deal with their personal cycle. A woman's personal calendar has the space to be filled in. Should she start day one, not 12 days before the lunar cycle, she can write in her own doses. Of course, that would populate an electronic app. And then she can keep track of her symptoms. If she has a headache on day 8, she's going to write it down. This is going to give you something to work with, because the alteration of the Wiley Protocol, the clinical practice guidelines, will tell you that fixing an aberrant symptom, or one created by the protocol, or one not obliterated by the protocol, must be done in a timely fashion. So you have to know when it happened. This is a lunar calendar showing the doses for the basic Wiley protocol as they would exist. The highest dose being on day 12, that's 8 lines morning and night, and the lowest dose going back to day 1, 2, or 3, which is 4 lines morning and night. The lunar calendar is in the absence of menses. If a woman has not had a period in 20 years or 2 years, if she's been robbed and has no uterus, and you understand uteruses are removed because they won't behave. A uterus that's a problem, whether it's cancer, fibroids, or uncontrollable bleeding, is only responding to the software programmed by the hormones. So if a woman has a uterus that won't behave, you have a chance to reprogram it, not, throw it away, not take it out. But if it's gone, if she doesn't know the first day of her last cycle, because it was so long ago, we use a lunar calendar. Menstrual correlates to the light values of the respective phases of the moon due to the interplay of other hormone receptors, predominantly melatonin. When the light is bright, melatonin is down. And melatonin, being an estrogen blocker, leaves the estrogen receptor wide open. And we pour the most estrogen on that day, and the receptors are ready to receive it. For example, day 12 of the lunar cycle is always the full moon. So without a calendar, you could count back from the full moon, finding it, Googling it on the internet, or you could find another calendar. But counting backwards always gives you day 1 of the last menstrual cycle. But you must urge them to keep a calendar for your benefit. This is another piece of evidence showing you how the full moon is sometimes represented. The green ones are day 12, and we count backwards. In this one, they're actually green. You can see in July, the 2nd was the full moon. June. In July, you can see it was Wednesday. In August, you can see it's going to be on a Sunday. You can see the rhythm of the full moon just looking at 3 cycles of the moon end to end. And that's how it works in your patient. There's a rhythm, up and down, up and down. Always sync the Wiley protocol to nature. Once again, no uterus, stop cycling lunar calendar. Once the patient starts to have a period again, follow her new cycle. And what that means is she may start on the lunar cycle, but once she has enough receptors that we have a brain to uterus or an HPO, hypothalamic pituitary ovarian axis, recreated, she may fall into breakthrough bleeding or an early cycle that indicates her brain remembers what her cycle was. If she bleeds early, start over. Call it day 1. This should straighten out her cycles. If after 3 cycles she's still bleeding early, you're going to raise the peak of estrogen to get her some more progesterone receptors. But we'll discuss that later. The lunar cycle, again, day 12 equals the full moon, lots of light, low melatonin, estrogen receptors wide open. Men on the Wiley protocol, the male Wiley protocol, sync their dosing with their female partner's personal cycle or lunar cycle. If their female partners are no longer cycling normally, they both use the lunar calendar to reestablish normalcy, and same-sex males or men without a partner on the Wiley protocol for men will use a lunar calendar. Women and light are drivers of the male cycle. You may have some lingering questions. The biggest question a doctor's ever asked me is why give progesterone when a woman doesn't have a uterus? We have progesterone receptors in our breasts, our brains, our hearts, our bones, GI tract, neurons. The entire body responds to progesterone. Progesterone is osteoblastic and rebuilds bones after estrogen eats it up because you want very strong bones every cycle. It remyelinates neurons because estrogen will demyelinate neurons and is progesterone, of course, apoptotic. It causes falling away from life. It causes cells to devolve and be absorbed when they're no longer needed, such as the uterine lining and in breast tissue. Not just in the uterus. Breast, bones, hearts, GI tracts, neurons. That's why progesterone is so important. And estrogen. You must replace hormones physiologically with that rhythm to get the optimum good health for your patient. Remember, women must have a period to stop the deterioration physiologically. In normal life cycles of everything on this planet, growth, death, growth is the rule. So growth and death in bones, breast, brain, heart, and uterus are the rule. Normal cycle is the best monitor of health and hormone levels in young women. And by normal cycle, I mean a normal menstrual cycle. A normal period tells us the brain, the body, and the pseudo-fertility you've created, that doesn't mean a pregnancy, tell you that you're in an optimum state of health with that patient. Apoptosis or controlled cell death occurs everywhere in the body. Again, brain, bone, breast, and heart. Perfectly timed by the dosing schedule that mimics youth. Apoptotic events are not possible without the day 12 peak of estrogen and its provocation of a normal progesterone receptor to create apoptosis throughout and vascularization throughout the luteal phase. Otherwise, it's just progesterone down a cortisol receptor. Gene activation. There are over 4,000 gene products and more than 400 physiological processes that are dependent on normal rhythmic production of estrogen and subsequent progesterone activity in young women. That means you can assume in a patient no longer menstruating with hormones that are deranged or static, 4,000 gene products and 400 physiological processes are dead. Now we have a quick start. If you'd like to put a patient on the Wiley protocol after all we've covered, this is the initial patient intake. It's not very difficult. It's actually simple, mindless. All you need to know is how old you are. What's the age of your first period? How long since you menstruated? Do you have children? At what age did you give birth? How were your pregnancies? Did you nurse? How long? What are your sleep patterns? What other medications, hormones, or supplements are you taking? You need to educate the patient about the contraindicated substances discussed on the direction sheet at this point in time. Do you have a history of uterine fibroids? Are you physically active? Do you drink alcohol or smoke marijuana regularly? Most menopausal and perimenopausal women can't sleep, so they put themselves to sleep with alcohol, which wears off in the middle of the night, or marijuana for anxiety. It's an important question because both will interfere with the hormones once they take them. There are very few basic tenets of the Wiley protocol. You need to remember them. If she has a uterus, you must restart a period. There is no possible augmentation of hormones because exogenous trumps endogenous. When you put hormones in from the outside, you lower or obliterate any hormone production in the patient. This is evidenced by using birth control pills to straighten out a bad cycle in perimenopause. And this is a known fact in endocrinology. Exogenous trumps endogenous. So, no half doses of the Wiley protocol, no quarter doses. You would only be lowering what they have, and you might wipe out a deranged cycle, but you're not going to get a menstrual period. You're not ever going to get to the levels that trip gene activity. The bare minimum of activity, positive outcome in the Wiley protocol is the basic dose. Now, all women are not the same. So you can do +1, +2, +3, or even +4, or even 3 times a day. Because you want to make that woman feel like she did before. You want to get blood tests that work. But before you can ever do that, you must make them all women again. And that is the basic Wiley protocol. Too much hormone is like none at all. Before you give it 3 times a day, before you ever go over +4, you must understand you'll turn off the receptors. So too much hormone is like none. Symptoms are the same as no hormones when you've given too much because the receptors become resistant, just like insulin resistance when insulin pours constantly. Never go above E2 +4 TID. If the woman does not feel better, if the results are not normal, then we must re-examine her absorption of the hormone. We must examine if you've given too much and she doesn't feel good. You would start by spreading out the BID doses to make sure the receptors have normalized. But we're going to talk about that in a minute. Separate applications of E2 and P4 on separate arms. Progesterone goes on one arm, estrogen goes on the other. Putting progesterone or estrogen on inner thighs and legs has been tried, and the result is very different because adipocyte response is site specific. For example, belly fat is androgenic. You would like to put it on the crook of each arm and up the tricep in the back, where you make a depot, a deposit, so that every time her heart beats, she gets that pulsatility we've looked at in those pictures. Other than a pump, which doesn't exist yet, it's the best we can do. We create pulsatility with the fat depot, and we create amplitude with the dosing. You must wait 3 months until all the estrogen and progesterone receptors have built a complement and are working to measure thyroid and testosterone. And that would be on day 14, because on day 14, the inverse rhythms of thyroid and testosterone mean you're going to get a picture of the most she ever has on day 14. And most importantly, to my doctors, to my pharmacists, never prescribe or dispense progesterone or estrogen alone. No estriol ever. E3 is a hormone ubiquitous in pregnancy from the baby's adrenals. No woman post-pregnancy is in the 20/80 ratio or state beyond 9 months. Now, Dr. Jonathan Wright in Biest and Triest, which was promoted at many alternative medicine conferences, would tell you that that's safer. It is not safer. E3 is a metabolite of E2. You can see E1 goes to E2. E2 can go back. The metabolite of both of those is E3. E3 is an estrogen receptor beta, not alpha, agonist only. So there's no bone protection, there's no cardiovascular protection, only provokes an E2 receptor, which in fact can be dangerous. What we know is if the woman has very low proliferation from E2, because there's no rhythm, and you give her consistently E3, you're going to make some more alpha receptors for E2, and you're going to make more proliferation. You're not going to stop it. There are thresholds and crescendos for G1 arrest, and you will never, ever reach them. You know, in the arrow picture above, E1 to E2 to E3, you must remember that 80-20 state is illogical because it insinuates 20% estrogen and 80% estriol. You can never have more metabolite than you have precursor. Doctors fear E2 due to their mistaken fear of breast cancer. E2 is an agonist of estrogen alpha receptor and causes G1 arrest. You remember that stops cancer and proliferation. This slide is very confusing. On the left, we have active estrogen, or E2, and of course the reverse possibility to estrone. We can see estrone sends you out to the metabolites that are dangerous, carcinogenic. And we can see that estriol sends you to the metabolites that are anti-proliferative and positive. So when you give someone DIM, you're destroying the potential of cancer fighting by E2, and you are enhancing estrogen's debilitating effects on the metabolites in the breast. And we know again that estrogen is the most ubiquitous estrogen found in frozen breast cancer slides. No mammograms ever, please. Mammograms increase overdiagnosis, finding benign cancers that would have never killed women. And it leads to treatments that include surgery, chemotherapy, radiation that can kill women. Overall, 22% of mammograms detected invasive cancers that weren't even there, that weren't invasive. That means that one overdose breast cancer for every 400 women who receive mammograms on the screening trial creates treatment in that woman that could kill her. And it is well known that 75% of all ductal carcinoma in situ will never become metastatic. I would argue that if you treat it, you might push it in that direction. This newspaper article on a scientific journal article came out. The title of this slide is "Please, Again, Do Not Irradiate Your Patients." Studies from BMJ on 90,000 Canadian women showed death rates from breast cancer from all causes were the same in women who got mammograms and those who did not. I would argue Canada was trying to catch up for an earlier study that said women who got mammograms had more cancer than women who didn't. You can find that study in my book, Sex, Lies, and Menopause.